healthcare is not complicated. It's easy to understand why it's messed up. The incentives are all wrong.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we have Dr. Eric Bricker here on campus at UTD for the Business of Healthcare podcast. Eric is an internal medicine physician and the Chief Medical Officer at AHealthcareZ. He's also the former co-founder and Chief Medical Officer of Compass Professional Health Services, which was acquired by Alight Solutions. Welcome to the podcast, Eric.
Great to be here, Bob. Thanks so much for having me.
So I've been looking forward to meeting you in person. I've been following you on a regular basis through your AHealthcareZ Finance Video Journal. What a name, AHealthcareZ. Right. Tell me about that.
Well, everything in healthcare is blank health. And so I didn't want to follow that same rubric for a name. And I'm not very creative. So I'm like, okay, well, let's just put an A at the front and a Z at the end. And that domain was available. So there you go.
I know that your video journal, I've looked at a lot of those, and you focus quite often on insurance brokers and benefit consultants and also HR professionals. But I kind of think of you as, you're familiar with the Khan Academy?
Sure.
And Sal Khan just started off talking about things that were important to him and that he could relate to. I kind of think of you as the Khan Academy of the healthcare here. So tell me a little bit about your background. I know that you're from Johns Hopkins. That's your
I do my residency there. Yep.
Okay. But kind of give me a little background on your entrepreneurial spirit and how you got to where you are today.
Sure. So originally from the suburbs of Washington, D.C., did my undergrad at Northwestern just outside of Chicago. And this was in the late 90s when everyone and their brother and sister wanted to be a physician. So everyone told me, you're not going to be able to get into medical school. And so I pragmatically, I was an economics undergrad because I wanted to be able to get a job in case I couldn't get into medical school. And one of the books that we read in our intro to macroeconomics class was specifically about healthcare economics and how Hillary Care was going to fix everything. And so I was just fascinated by it. But then I thought, oh well, it's I'm too late. They're going to have this thing solved before I graduate from college. And applied to the Peace Corps. Decided not to go because there was active fighting in the country where I was assigned to, and so worked for a couple of years as a hospital finance consultant. And while I was doing that, I took my MCAT and did my applications for medical school. And really, in the late 90s, they were just giving jobs away. You couldn't not get a job out of college in the late 90s. And so I was hired by a bunch of Accenture, used to be Anderson Consulting at the time, folks that just did hospital revenue consulting, revenue cycle consulting. Was just working in the accounts receivables department. And they literally used paper bills back then. It was fascinating. Learned all about ICD-9 and CPT coding and how all the billing works. And we literally would see stacks and stacks of bills underneath potted plants in the billing office. And of course, if you don't send out the bill, you're not going to get paid. So we would work with them to got to lift up the plant and send out the bills. And so, you would literally liquidate between $30 and $120 million of receivables for the hospital. And some of these hospitals were having a hard time making payroll. So they really needed the money. And so did that for a couple of years. It was a fantastic claims experience. This was also when managed care was going on. So every single physician that I talked to said, whatever you do, don't go into medicine because the HMOs have just ruined the practice and all this bureaucracy, pre-certification, yada, yada, yada. So I wanted to learn about that so that if I wanted to still go into the profession, I would do it eyes wide open. So after 2 years of that, I still wanted to be a physician, but I knew I didn't want to be sort of your traditional, grinding 25, 30 patients a day. I wanted to kind of marry the two, the business and the economics with the practice of medicine. And so then went to the University of Illinois at Chicago for medical school. And UIC is great. It's almost like the UTD of Chicago. It's very similar in terms of size and the types of students that it has. And it's where the main medical school for the University of Illinois is, because down in Champaign-Urbana, where the main undergrad campus is, it's a relatively small town. So you can't have the big hospital there. And UIC is fantastic in that it actually sends its students all over the city of Chicago. So we would train at the Cook County, which is where the TV show ER was based in. So literally that alleyway that you remember from the TV show, that alleyway actually exists behind the hospital where the ambulances would pull in. So I did my family practice rotation to Cook County. They sent us out to the VA, all sorts of different hospitals all over the Chicagoland area. I did OB in a community hospital out in the suburbs.
Well, the big thing, did you get a cameo appearance in ER?
No. However, you would see them doing the area shots around the city because the show was still very popular at the time. So I did see Eric LaSalle one time close to the hospital. So it was just probably the best experience possible for being in, quote unquote, healthcare finance because I got to see everything. I got to see government-run healthcare with the VA. I got to see an academic medical center. I got to see, large, tertiary referral center. I got to see community hospitals. So it was great. Totally by accident. It was a fantastic experience.
So now you're a medical doctor and you're still in Chicago?
So yeah, and then I applied to residency at Hopkins in internal medicine because I'm originally from Maryland, was fortunate enough to be accepted there. Hopkins is really close to the Centers for Medicare and Medicaid Services, CMS, which is outside of Baltimore. So I thought this would be a great way to get involved in like healthcare policy, and I kind of wanted to be a policy wonk to help solve some of the problems that I was seeing through policy. And then I got to Hopkins, and I quickly realized that I did not want to do that. So it was just a fantastic clinical experience. Obviously, not a lot of sleep. Interestingly, I didn't get to eat much. I didn't realize that when you're a doctor, you don't get to eat. So it was just incredibly learned a ton. And basically, the Hopkins model is you just see a gazillion patients every day, and that's all you do. And so I just saw so many different. It's Hopkins is called the land of princes and paupers because literally in one room you would have a Middle Eastern sheik who took his own personal 747 to come to Hopkins, and in the room next to him would be a homeless guy. Yeah. And, both dealing with, let's say, multiple myeloma or some sort of condition. So it was just a fantastic experience. While I was in residency, I kept in touch with one of my consulting colleagues who had gone on to become the EVP of finance of a very large healthcare system. And he and I were seeing the challenges and wanted to attack it from a business standpoint. And so that's why we formed Compass Professional Health Services. We then had a third partner join us. And so I actually had to get special permission from the head of the Department of Medicine to start a business while I was in residency. It was very odd. And I assured them it would not take away my time. It would not conflict with Hopkins. And then my plan was to then move to Dallas where they were located after I graduated. So the reason that Compass is based in Dallas is just because that's where the other two founders are from. They were already here. And we really saw as an internist, there was a million things that needed to be done to help people navigate through the healthcare system in regards to their paperwork and their bills and referrals and just care coordination, and no one was doing it. And a lot of times the internists don't do it either because they're not paid for it. Back then there was no CPT code for outpatient care coordination, and so we said, hey, if we could take what we knew as doc and hospital insiders and bring that directly to people, that would be very helpful for them. And we learned, of course, being very naive, we didn't realize that most people in America get their health insurance through their job. And so they don't even think of that as, quote unquote, healthcare, health insurance. It's employee benefits.
Yeah.
So we had to learn about employee benefits. And so that's why we started Compass and sold it as a benefit to go along with the benefits package, along with their medical insurance, dental, vision, et cetera. And then they would get their Compass Personal Health Pro Navigator to help them navigate through the healthcare system along with their benefits.
So as an entrepreneur, you find yourself in Dallas, Texas with a new company that you have your partners with. And what year is that?
We founded the company in 2007.
2007. So as you set out to look at this mess that the healthcare industry's been a mess for a long time, like you were hopeful that it'd be all fixed up by the time you got out of medical school, which is not the case. It's still in a mess today, as we all know. We talk about that in a whole variety of different formats. But there you are as an entrepreneur addressing the marketplace. Who do you go after to start this business of healthcare?
Yeah, so that's a great question. And it was a real exercise in trial and failure and learning because as the chief medical officer of Compass, I was the sales and marketing guy. So I would go out and I had to learn how to sell. And I would say if there's any entrepreneurship shouldn't even be called entrepreneurship, it should be called selling. Because unless you sell something, no one's going to buy it and you have no business.
Yes.
So selling starts everything. So you have to know how to sell. Okay, one. Two, in business, so healthcare is essentially a business-to-business proposition. It's not business to consumer. And in business-to-business especially, and in benefits especially, and it's in HR especially, it's highly relationship-based. And it highly depends upon the sale and the sales process. So you're not going to market your way to success. To a certain extent, you have to have a sort of, value proposition that's 10x, that differentiates yourself from the market. But even if you have those things and you can't sell, you will fail. And so I learned that quickly. And so to answer your question, what I did was I approached small and medium-sized businesses because there were a lot of them. Mm-hmm. And I got a lot of at-bats. And I totally screwed it up for a year. I had a year of complete failure hanging up on me. I'm a physician that actually cold calls people. I don't know how many doctors in America cold call, but I actually do that. You should hear the people. I'm Dr. Bricker. I'm an internist. They'd be like, "Why are you a doctor calling me?" Right. It's very odd, but it was great because it had good interruption value, so I could start talking to them, and we would have these discussions. And so over time, I would then learn how to, essentially the consultative sales process, to learn their pain points, and specifically the business proposition was in 2007, was right when consumer-directed health plans started taking off, where people started having a higher deductible with an HSA plan, where employees actually had more financial responsibility and they had no idea how to use it and they had no guidance. And so we said, look, if your company is either putting in a full replacement consumer-directed health plan or a dual option where you could choose between the PPO or the CHP, you have to put in Compass, because if you don't, your employees are going to be lost, they're going to be angry, and they're going to be constantly calling your HR department asking questions. And the HR department is like, I don't want them calling me asking questions. Right. And the CEO is like, well, I don't want to make them angry, but if it's going to lower my health expenses by anywhere from 10 to 25%, we got to do it. So we were that adjunct tool to go along with a CDHP. And so in 2007, 2% of employees in America were on a CDHP. And when we finally sold Compass, it was over 30%.
And that CDHP is a consumer-directed health plan.
That's correct.
Right. So as you looked at the marketplace, you went from small companies and ultimately ended up with a lot of large name brand companies. So that movement from 2007 on, where people needed navigation and help, that was the primary guidance that you provided?
Correct.
And you called on HR executives?
Correct. HR, and a lot of times those decisions are made in conjunction with their broker benefit consultant. So it was really a combination of the HR folks and their broker consultant, because a lot of times the HR people really heavily relied on the recommendations of their broker consultant as an advisor. So we would market and sell to those brokers and consultants, and they would then distribute us out to their existing install base.
Okay. So kind of fast forward here, Aon, big company.
Sure.
They decided to sell its benefits administration and HR business process outsourcing. They sold it out to Blackstone.
Yep.
And Blackstone's an investment private equity group, and they decided to rebrand that as a new company called Alight.
Yep.
And Alight, they're looking at adding and expanding their capability, and they need to have healthcare navigation. So they come to Compass and they acquire you.
That's right.
So now what you had created now is part of Alight's healthcare navigation division.
That is correct.
Okay. So do you still have any relationship with them at all? Or are you totally...
No. In 2018, the summer of 2018, when it happened, myself and the CEO left. And so I have, I'm fine with talking about it. I have 3 kids, and my middle son is on the autism spectrum, and it made sense for me to spend more time with him. And so I'm doing just that, which is fantastic, and he's doing a lot better. And I just wanted to still continue to provide value in the healthcare space, which got me to AHealthcareZ.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So the vision you have for AHealthcareZ, I think of it as an education vision.
Yep.
You're trying to educate, continuing this education process.
That's right.
And I think it's got some value going forward. Obviously, people that watch your videos, it's a free subscription.
Yep.
Okay, so you're not trying to monetize this in any form or fashion. You're trying to create and add value and create awareness. So you're really tuned in to a lot of the different things that are taking place. Like, for example, some of the healthcare basics. You're looking at employers, insurance companies, employees, healthcare providers. You explain these in financial terms quite often. Is that something that's going to go away as we look at the new healthcare 2.0, 3.0, 4.0, the changes that are coming? Is there still a need for that type of education?
Well, I think so. And one of the things that is common about healthcare is that it changes very slowly, right? Healthcare did not get fixed in the late 90s like I had thought. And so people always talk about change being needed in healthcare. I mean, hey, Richard Nixon talked about change being needed in healthcare in the 1970s. So it is always going to be changing, and it's going to be changing slowly, which is why people need to be continually educated about that. And what I saw in those 10 years of sales meetings at Compass was still a real lack of understanding of the real problems that employers were having in terms of their healthcare cost and quality. And so if people were bringing in any type of innovative solution, whether it was us at Compass or their carrier or any other vendor, the employer had a hard time understanding how it was going to solve their problem because they didn't even know what their problem was. And so that's why I wanted to take this opportunity to create these short, 3 to 5 minute videos to explain to them, hey, look, you have a PBM spread pricing problem. Hey, look, you have an employee primary care problem. Hey, you have specifically a high-cost claimant problem in orthopedics, cardiovascular, and cancer care, and let's talk about specifically why that's driving your claim costs, and then what are some things that can be done about it. And that really requires drinking from the fire hose, which I cannot accomplish in a 60 to 90-minute sales meeting. But this way, the brokers can educate themselves, and a lot of them then take these videos and they forward them on to their clients. So I kind of jokingly say that I'm like softening up the beaches so that when innovators come in and propose a lot of really good solutions, then the buyers actually have some context now to within which to put that solution.
You use my favorite word, innovators, innovation, and there's a lot of disruptive innovation on the horizon. Let's talk about that for a few minutes. Looking out at some of the changes we see take place, CVS stands for the Customer Value Store. They now have an insurance company. They've introduced or getting ready to roll out like 1,500 or so health hubs,
right?
Really addressing primary care. How do you see that making an impact in the industry?
Yeah, and so I will tell you that I'm highly suspicious. So you always have to trust but verify. I don't want to say cynical, but I'll say trust but verify, okay? In that, Charlie Munger, who's the vice chairman of Berkshire Hathaway, said, look, healthcare is not complicated. It's easy to understand why it's messed up. The incentives are all wrong. So anytime anyone makes any quote-unquote strategic move or innovation in healthcare, it's important to ask yourself, okay, what is the reason that is being said and what is the real reason? Because oftentimes they're different. And if you want to find the real reason, you look at the incentives. And then it's like, oh, that's why they're doing it. So I don't know if we want to get into that specifically for CVS, but it's important to look at the PBM business model and how they make money and find out how having health hubs would actually increase revenue for a PBM. Remember, CVS Caremark is the PBM that they bought. CVS Caremark makes more money off their PBM than they do off their stores.
Yes.
And it's also the larger growing part of their business. So a lot of that health hub is going to, listen, they have a fiduciary responsibility to their shareholders. Like their shareholders are like, you have to maximize your profit or we're going to sue you. So you have to ask yourself, okay, what is the motivation? What is the incentive for CVS to do that?
There might be competitive pressure here. So another innovative change taking place. We see now Amazon is licensed to be a pharmacist in many states. And with their pill pay that they bought for several or at least $1 billion, they have come up with an innovative way to deliver pharmacy directly to the home in a really pretty profound, user-friendly customer experience way. So when you stop and look at, the competitive advantage of someone like Amazon trying to be the pharmacy, and you look at CVS saying 60% of the people go into a CVS store to go to the pharmacy counter. So now they're really trying to add the mini clinics and other value-added points with these health hubs to really maintain that position and add value. And quite honestly, I don't see why they couldn't offer, primary care services in those facilities. And then we add into the equation Walmart.
Right.
Walmart now in Dallas, Georgia has opened up, an experimental. That's how Walmart got started in the beginning, was in small rural areas.
Right.
And I can tell you the people in Dallas, Georgia would welcome a clinic where they can get great value and service like that. So there's a lot of things that are happening out there. So I think the challenge in front of us still is education. And obviously, the topics, the politics, without taking a political view per se, but we just had a symposium here at UT Dallas on Medicare for All. Okay. The different flavors of it, the different potential ways it could be addressed and looked at. And, we're going to hear a whole lot more of that. The election's about a year off now.
Sure.
So we're going to hear a lot of campaign stumping taking place on the healthcare, the costs associated with it and things of that nature. But I'm really glad to see that we're trying to address some of the real fundamental aspects of healthcare. What do you see are some of the biggest challenges right now in this disruptive environment?
Well, I think that one of the best places to look is the Intermountain Healthcare System in Utah, and they do a lot of very smart, innovative things. And part of the reason that they are so innovative is because they actually run a health plan. So they actually collect premium from Utah employers and provide the care. So they're like a quote-unquote fully integrated healthcare system. So they take on the risk and they provide the care. And it's amazing. It's like, okay, Utah, yes, there's a lot of wonderful people there, but why would Utah be a center of healthcare innovation? Same thing with Kaiser in northeastern Pennsylvania. It's like Scranton. Like, why would Scranton be a center of healthcare innovation? Again, it's because of the incentives. It's amazing what happens when you align the incentives. So when you're collecting premium and taking on risk and providing the care, it's amazing what happens. And here's how I'm going to answer your question, is that Intermountain has realized they don't run one health system, they run two. They run a health system of specialists, and they run a health system of primary care. And the motivations and the way that those two different camps of their healthcare system practice is very different. And so for an employer or for the government or anyone who is either buying or consuming healthcare services, it's important for them to not think of quote unquote healthcare as healthcare. That's crazy, right? You don't think of 20% of the U.S. economy as like one monolith, right? It's not a monolith at all. Right. Intermountain has two separate healthcare systems. And if you are a primary care physician, your job is to keep people healthy. It's preventative care. It's catching things early, right? It also doesn't make sense for primary care physicians to be paid on a fee-for-service basis, right? Because ultimately, if you're doing your job, you don't want them in your office.
The population health model really exactly starts to apply there.
They need to be on salary. At the same time, you would never put an orthopedic surgeon necessarily on salary because they absolutely, on a transactional basis, are fixing broken bones. And so really, a lot of the innovation in healthcare needs to understand that dichotomy and then applying that. Classic example is healthcare IT, right? Where healthcare IT is so bad. It's been bad for forever. And one of the reasons for that is because the systems and the software is trying to design everything for everybody, whereas those populations are very different in terms of what they're trying to accomplish.
Yes. Well, let's shift gears here for a second. A while back, we interviewed Dr. Marty McCary with his new book, The Price We Pay. He is a Johns Hopkins alumni, as you. And you now have your first book, just came out last week, and it's called Healthcare Money Campfire Stories.
That's right.
So why don't you tell us quickly what that book is about and why you wrote it?
Well, it is 16 true stories from my experience in medical school and residency and at Compass. It's short. The entire book is like 129 pages. Each one of those, it's kind of like, it's kind of corny. I loved those Chicken Soup for the Soul books back in the 90s, right? So it's kind of written in Chicken Soup for the Soul type fashion, right? No one has time to read anymore. But if you can just pick up something that you can, go through like 4 or 5 pages real quick and then put it down, wonderful, right? Healthcare is boring. I mean, even for me, and I'm into this, finance is boring. right? You put the two together, it's incredibly boring. So I can't even keep my own eyes open when I read healthcare finance books. So how in the world? One of my favorite authors is Michael Lewis, and Michael Lewis says, your first job as an author is to not be boring. And so that's why I wrote it in sort of it's the kind of stories you could tell around a campfire, right? It's got a beginning and a middle and an end. It's got suspense. It's kind of funny. I mean, we got a quadriplegic drug dealer who's telling me about the war in Afghanistan after 9/11, and he's educating me on foreign affairs. I mean, it's like you could not make this stuff up.
It sounds like a good anecdotal read for sure.
I mean, and so what I wanted to do is just weave in how important money is in healthcare, and it's so important because it's so not obvious. It's hidden. And that's the root of most problems, right? Most problems never get solved because they're hidden. And so the way you actually fix the problems is to make them apparent. One of the most famous doctors in America, the guy who actually started the Department of Medicine at Johns Hopkins, was a guy named Dr. William Osler. And he said in his book that healthcare is not a business. And he knew that back at the turn of the century. And that's true. If you have someone who is it's like a fireman being a business. Oh, I see that you're about to die. How much would you like to pay me to save you, right? That's not a business. You have perfectly inelastic demand. You could charge whatever you want.
Yes.
Healthcare, if you have a perfectly inelastic demand situation, that's oftentimes why government provides those services. So not all healthcare has perfectly inelastic demand, but when it does, it's not a business.
Yes.
So the way that you address that problem is to look it square in the eyes. And so that's why I wrote the book, is so that people can actually see how money is manifesting itself in healthcare.
Well, we could spend another hour talking on topics like transparency, but I don't think we've heard the last of you, Dr. Eric Ricker. This has been an enjoyable time. I love your energy, your knowledge, your experience, and your willingness to share. So thank you for being part of our podcast today.
Bob, thank you so much for having me.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.